Good afternoon, everyone. My name is Richard Lauby. I'm the CEO of Noble Biocare, and I would just like to give you a few brief introductory words. I think we have a wonderful program for you this afternoon. PI's words to us were, "No one should die with their teeth in a glass of water." And he said that many decades ago, and he's been a missionary in fulfilling that dream and vision. And we have taken those words again, and we have added new meaning to them for Noble Biocare.
Our next speaker is well known to all of you. Dr. Bahat completed his undergraduate dental degree in South Africa, which is why he has that funny accent. Not really. Followed by postgraduate training in periodontology at the University of Washington School of Dentistry in Seattle, where he received his Master of Science in Dentistry. He's a fellow of the American College of Dentistry and a diplomat on the American Board of Periodontology. He has also held the position of director of the postgraduate residency in periodontology at the University of Southern California School of Dentistry in LA. He's considered an expert in surgical reconstruction associated with compromised bone and implant placement. In addition to maintaining a private practice in Beverly Hills, which I haven't been to, he lectures extensively both in the United States and internationally. You're in for a treat. You're in for a learning experience of seeing some very difficult cases treated very precisely. It's not your everyday type of stuff, and he puts a different bent on it. So I'm very happy to welcome to the podium Dr. Oded Bahat.
What I will try to discuss with you today is surgical reconstruction of the anterior ridge. Surgical reconstruction is a little more difficult, more challenging, and takes more time. And I don't think that in medicine it is even a question. You'll never let a patient who is amputee and offer them lifetime this way. It's not even an option. You will always reconstruct. So the question is dentistry different than medicine? And for me, not. Well, our eye functions basically like a very sophisticated lens, which picks up lights from areas of convexity in our face and shadows. This allows us to see dimensions, allows us to discern distances. So on our face, if you study it through PET scans or MRIs, you'll see that when our eye catches light that is reflected from some areas that are highlights, and you'll see it in a second. If you see a PET scan activity or an MRI activity, the neurons will fire very slowly. If you see a groove or irregularities, more neurons will fire faster and will take more activity. And that may explain physiologically what we call something aesthetics, something less aesthetics, something that is aged, or something that is not aged. The 7 highlights, which are always lined by skin and fat is lost through aging. At the above, they look like Fabergé eggs or those elliptical structures. It's on the eyebrow, the eye itself, the cheek highlight, the lips highlights, the jaw highlights, and the chin. Now, in surgical reconstruction with implants, you can influence the lower third of the face. You will always, if successful, be successful. So this part, you can change through what we do. Now, there are 7 angles that also dictate facial aesthetics. And the one is the brow angle, which will go from mid-decanthus to the junction of 2/3 and 1/3 of the eyebrow. The eye angle, which goes from the horizontal, from the mid-decanthus to the lateral. The cheek angle that you're all familiar, that's what the plastic surgeon and the dermatologist use a lot of fillers. The lip angles, the jaw angle, and the neck angle. The last 3, again, will be affected by what we do. Now, what about intraoral aesthetics? So I know what I want to get extraorally, but what do I want to get intraorally? And what I have to get intraorally with implants or without implants is the same. So when we have a defect like that, we have to reconstruct. And I'll emphasize primarily on corticocancellous or cortical bone, simply because it is, in my opinion, still the golden rule. But if you like other materials, that's fine. I would just tell you that vertically or horizontally, you will not be successful with more than 4 millimeter defect. And if you are, I'd love to see it because it will cut down on me going to an extra oral site. Now the trick here, we are building it away from blood supply, and blood supply is the limiting factor. So how much can I stretch the envelope without failing miserably? Well, we can get into here. And if successful, remember we talked about the influence of surgical reconstruction, what we do, not the plastic guys, on extraoral aesthetics. Well, if this is the appearance of the patient pre, this will be the volume of the upper lip. This will be the volume subsequent to reconstruction. This will be this elliptical pre and post. The upper lip before and after reconstruction. When you look in an anterior view on this patient, before and after, now let's look at the angles. We increase upper lip from 5 millimeters to 8 millimeters. We increase the angle from 30 to 42 degrees. It is important that we emphasize that to our colleagues in plastic surgery, to our colleagues in dermatology, to our prosthodontists, that we can do that with implant reconstruction of the anterior ridge. And that's a massive change for the patient. Now, this type of reconstruction will only affect the lower third of the face. But since it's affecting the upper lip, it would have also influence on the cheek angle. So it does change aesthetics. In expansion, you place a device, you expand the tissue. It's done in burn injuries, it's done in cancer surgery. You expand it, expand it, expand it. Once you have enough, you remove the expander and you place the bone graft. The anteriorly advanced flap, which is most what we do, consists of 2 parallel incisions. Raise the full flap, keep on advancing it until it's completely passive. Once it's passive, you can do the 2 back cut incisions. So you have 2 parallel limbs and 2 back cuts. That's a basic.